Thank you, Sammy. Thank you, David. It's really a pleasure to be here and look forward to a fun-packed day with more live cases. So I've been asked to speak on endoscopic therapies for pancreatic fluid collections, and I have to really say I find drainage of pancreatic fluid collections, really one of the most gratifying procedures. It's like removing a stone in a patient with cholangitis. You can give these patients immediate relief of their symptoms. Here are my disclosures. And the learning objectives are, firstly, to understand the revised Atlanta classification of pancreatic fluid collections and how it impacts management. Second, to list indications for treatment of pancreatic fluid collections, and to outline strategies to improve the outcomes of endoscopic treatment. So let's first talk a little bit about terminology, because it's important that we all speak the same language. Historically, we have used the term pseudocyst very loosely to describe any fluid collection in and around the pancreas. In 2012, the revised Atlanta classification was published, and this classification differentiates 4 distinct subsets of pancreatic fluid collections. And so first we have an acute fluid collection. Second, an acute necrotic collection. Third, a pseudocyst. And fourth, walled-off necrosis. Now, in the original classification, there was only a differentiation of an acute pseudocyst from a chronic pseudocyst, and a chronic pseudocyst or a pseudocyst from an abscess. An acute pseudocyst was a pseudocyst that occurred in the setting of acute pancreatitis, and a chronic pseudocyst in the setting of chronic pancreatitis. So this is a very different classification. And why this differentiation? Well, it's based on a better understanding of the natural history of the disease. Acute pancreatitis, in 85% of the cases, will evolve to interstitial pancreatitis. And a subset of these patients will develop acute fluid collections. 15% of patients will develop necrotizing pancreatitis, and a subset of these patients will develop acute necrotic collections. Now, if an acute fluid collection persists for more than 4 weeks and develops a mature wall, then we call that a pseudocyst. If an acute necrotic collection persists for more than 4 weeks and develops a mature wall, we call that walled-off necrosis. What is key is that a pseudocyst contains fluid only, and a walled-off necrosis, or WON, contains both fluid and necroses. Therefore, the term pseudocyst should be used only for fluid collections that consist only of fluid with the mature wall that have been existent for more than 4 weeks. So how do we differentiate a pseudocyst from a WON? I apologize, somehow the slides, something's missing here. We're missing a picture here. The Atlanta classification provides us with criteria based on contrast-enhanced CT. Now, as we'll learn in a moment, that is actually inadequate to make this differentiation. But per the classification, both of these have completely encapsulating walls. A pseudocyst is homogeneous, and I apologize that the image here is missing. It is a low attenuation fluid density. A WON, by contrast, is heterogeneous. It contains both liquid and solid densities. So a pseudocyst, again consistent with the definition, has no solid component. The CT, however, is very poor at identifying a solid component. And that's the reason why usually in the reports, on the CT scan reports, the collection will be described as a pseudocyst, because the radiologist can't really identify that solid component. An MRI is much better at detecting solid debris on the 2T weighted images. In one study, comparing the sensitivity of MRI versus CT in the detection of solid debris, the MRI was 100% sensitive versus only 25% using the CT scan. Now, of course, there are other advantages to using a MRI rather than a CT. There's a lack of nephrotoxicity because we're not using an iodinated preparation. There's a lack of radiation. We may also detect pancreatic duct disruption or obstruction, which may warrant an ERCP with stent placement. And we may detect the underlying cause of the pancreatitis if, for example, we see stones in the common bile duct. Now, the drawbacks of an MRI are obviously the cost and the availability. So when should we treat a pancreatic fluid collection? We follow the 4-week rule. We should delay until at least 4 weeks after the onset of acute pancreatitis to allow a mature wall to form. And there's only one exception, and that is if the collection is infected. So that mandates intervention. Now, that intervention could be endoscopic, but more commonly it'll be percutaneous drainage and sometimes surgery. What are the indications for drainage? Well, of course, infection. Now, the obvious signs would be fever, chills, leukocytosis, but remember that sometimes the patient may simply feel unwell. In fact, they looked at this population of unwell patients, and 40% of them had infected fluid collections. And on imaging, you may see gas bubbles like you can see here, indicating an infection. A patient with persistent pain or symptoms of a mass effect, outlet obstruction manifested by nausea and vomiting, biliary obstruction manifested by jaundice, or a patient may develop a compartment syndrome. And there are less common indications for drainage, such as a pancreatical pleural fistula. Now, what's different, what we understand today, is that size itself is not an indication for drainage. So it used to be size greater than 6 centimeters should be drained, or a cyst that's growing should be drained. That is no longer the case. So actually this year, 2015, celebrates the 40th anniversary of endoscopic treatment of pancreatic fluid collection. So it was 1975 that the first report of endoscopic aspiration of a fluid collection was reported. And that was done really to determine if the fluid collection was the cause of the patient's symptoms. It turned out that the patient was no better after the contents were aspirated by FNA, and therefore the patient did not undergo a surgical cyst gastrostomy. Fistulotomy was reported in the 1980s. Stent drainage was reported in the 1990s. So first, we weren't even using stents. We were just using a sphincterotome typically and creating an opening, a fistulotomy. And it was only 10 years later that we started putting stents to drain pseudocysts. EUS-guided drainage was first described in 1992, but actually there was no FNA needle at that time, so it took a number of years for EUS-guided drainage to disseminate. Necrosectomy was first described in 2000, so endoscopic necrosectomy. The first placement of a self-expandable metal stent was in 2008. And the first report of the use of a lumen-apposing stent that we'll talk about in a moment was in 2012. So this is sort of a quick overview of how this field has evolved over 40 years. I was in Hamburg working with Nibsa Hendra. In 1992, I and my coworkers there published on the first EUS-guided drainage of a pancreatic fluid collection. This was a non-bulging pseudocyst, so therefore we were at the time draining these endoscopically, but this was not a candidate for endoscopic drainage. So we used a prototype curvilinear array echoendoscope from Pentax, 2.0 millimeter channel, which meant that after we placed the wire in the pseudocyst, placed under EUS guidance, we had to switch out for a duodenoscope, and then we placed a 10 French stent. So that was the first EUS-guided drainage. And according to the Seldinger technique, today this is well disseminated. It's become the standard approach to pseudocyst drainage, and it consists of 4 steps. First, access, and usually we'll use a 19-gauge needle for this access, and we will aspirate and send off a sample for fluid analysis. Then we'll inject contrast. We'll place a wire and let it coil a few times inside of the cyst. will dilate the tract, and we're dilating it enough to enable us to place multiple plastic stents. But increasingly, endoscopists are now placing metal stents, just as we're placing metal stents in the bile duct. So when should you place a plastic and when should you place a metal stent? Well, plastic stent has the advantages of flexibility. It's very adjustable. It can be easily removed, and usually it'll actually spontaneously migrate out, so you don't even have to actively remove it. But the disadvantages are that the drainage, of course, is limited to the small diameter of the stent. These can therefore clog, and that's really the rationale for placing multiple stents, although it really was never proven that we have greater patency by placing multiple stents. A covered SEMS has a larger lumen, and it avoids aggressive dilation. So now we don't have to make that big opening to place just a single delivery catheter. The disadvantages are that this can migrate out. It has no flanges, a conventional tubular covered SEMS. It has sharp ends, and those sharp ends can cause trauma as the cyst wall collapses down. And obviously, there's the cost issue. So this year, just published, is a retrospective study that compares metal versus plastic stents for pancreatic pseudocyst drainage. There are a number of prospective studies that are in progress now in the U.S. and Europe. But this is a retrospective study, 230 patients, and the technical success was similar using plastic and metal stents. Resolution at 12 months was 6-fold higher for patients who had a SEMS placed compared to the double pigtail. 98% versus 89%. Now, 89% may sound pretty good, but if you're among those 10% of patients where you're not having a resolving cyst, then it actually means something. The adverse events were 3-fold higher in patients who underwent plastic stent placement compared with SEMS placement, and there was one serious adverse event, a perforation in a patient that had plastic stent placement as they were trying to place that second plastic stent to drain the cyst. There was no difference in the recurrence rates. So pseudocyst drainage is very different from the treatment of a wand. Here we need to perform necrosectomy. So we actually have to enter into the cyst and debride the contents. So we have to create a large opening, typically 15 to 20 millimeters, to enable passage of the endoscope into the cyst itself. And then we extract the debris. And we can use various off-the-shelf tools that we use in biliary endoscopy, baskets and snares and forceps, etc. So here you can see a large balloon. This is an 18-millimeter balloon to dilate up the tract to enable us to now go into the cyst. You can see the fenestrated opening, and then here an example of using a basket to remove the necrotic contents. And here I've compiled studies with more than 10 patients who underwent necrosectomy. The largest study was a multi-center European trial in 2009. And what you can see is that multiple sessions were required to achieve complete necrosectomy, on average 6 sessions in the largest study. And the complication rates are very high, with a total complication rate of 30%. So what are the challenges and risks of endoscopic necrosectomy? We have to aggressively dilate the tract, which can result in perforation, leak, and bleeding. We have to remove the necroses. That too can result in bleeding, perforation, air embolism, etc. Multiple sessions are required. And we can have blockage of the cyst enterostomy that can result in infection and sepsis. What are the strategies to improve the outcomes of necrosectomy? So this is the work in progress. We can use a larger bore SEMS, basically like an esophageal stent. That's been reported with and without necrosectomy. Nasocystic irrigation can be performed to continuously irrigate and flush out the necrotic contents and keep the contents clean. We can place multiple ports, the multi-gate procedure, and a combined modality drainage approach, either percutaneous or video-assisted. Another strategy is to use a Lumen-Apposing Stent. So this is the stent that I developed specifically to enable us to perform necrosectomy more easily. It has anchoring flanges, as you can see here, that prevents the dislodgement of the stent as we go in and out of this access port for passage of our endoscope and necrosectomy. It has a short length of only 1 centimeter that allows the cyst to collapse and will therefore minimize trauma. And because the stent is so short, we have to very precisely place the stent to straddle the wall between the cyst and the bowel. And therefore, you need a dedicated endosonographer-controlled delivery system that Luer-Lott's on the echoendoscope and really functions like an FNA needle. And there are separate hubs. Hopefully, we can show this to you today that enable us to advance our sheath completely independent of the device deployment, and we deploy the proximal and distal flanges completely independent of one another. And a one-device electrocautery enhanced delivery system is really the ideal because it allows us to place the stent immediately after we access the cyst, so we eliminate all over-the-wire exchanges. This is a video that very quickly will show you how we're just puncturing the cyst with this enhanced cautery system, and as soon as we're in the cyst, we can immediately deploy the stent. You see the distal flange deployed, and then the proximal flange, and voila, we have now drainage, and we have an access port now that we can create for necrosectomy. Here we're dilating up the lumen of the stent, and I'm going to quickly move to this video here that shows necrosectomy. For example, you can use a net basket to do this. So you can use various off-the-shelf tools to remove the necroses through the lumen-apposing stent. So here you can see we're grabbing chunks of this. And I'll quickly, because this thing is beeping, move on. You can see a big chunk of necroses coming out. And this is a study that that literally just appeared in GIE, reporting on results in several European centers using the electrocautery enhanced lumen-apposing stent. You can see that 60% of these patients, 56% had walled-off necroses. Many had infected necroses. Technical success rates very high, 99%. They used the so-called hot axios, the electrocautery enhanced system, in 74%. And let me just summarize then quickly. Firstly, I want you to remember the 4-week rule. You should wait 4 weeks from the onset of acute pancreatitis for the wall to mature, and we should only be draining symptomatic pancreatic fluid collections. And for pseudocysts, yes, plastic stents are the standard, but we should consider that the higher cost of SEMS may be offset by a higher resolution rate and lower adverse event rate. Consider an MRI to differentiate a pseudocyst from a WAN, and when dealing with the WAN, there's an editorial from Dick Kozarek with the title, "Not for the Uncommitted." You have to be committed. It requires planning, procedural dedication, and a lot of time, and multidisciplinary management. Thank you.